Good morning, dear friends. Today is the 6th of May, and we should continue our lecture. I introduce the head of our department, Emelianov Dmitry Nikolaevich.
Okay, morning guys. Today we start talking about lung disease. We'll talk about pulmonology. We'll talk about pulmonology, disorders of respiratory system. And today we'll talk about examination of patients with respiratory system problems. So let's start talking about respiratory system. You know that oxygen enables the breath of life. Without adequate lung function, lives can't be sustained. And you know about epidemic of COVID virus. Why people die in case of COVID-19? They die due to respiratory failure. They die due to damage of their lungs. So during 24-hour period, the lungs oxygenate more than 5,700 liters of blood with more than 11,400 liters of air in the lungs, and the total surface area of the alveoli of the lungs comprises an area larger than a tennis court. Just imagine tennis court, 100 square meters, and this is surface of our lungs. Now you know this picture. When we talk about respiratory system, we talk about bronchial tree. That would start from trachea, then left and right and left bronchus, which divided into segment bronchi, and finally we have bronchiola. And this is airways. This is airways tubes to deliver air to alveoli, because gas exchange happens in alveoli, and we talk about alveolar ducts and alveolar sacs, the small bubbles, small sacs, where we have oxygenation of blood, lungs placed in the chest. And you should know anatomy of the chest, because when we talk about signs, symptoms, we refer different anatomical positions, anatomical signs. So you know that we talk about actually clavicula, scapula, we talk about sternum, which consists of manubrium, then sternum and xiphoid processus. We talk about ribs, which connected to the sternum. No, actually, this is anatomy you should know. So let's start talking about main symptoms of pulmonary disease or respiratory disease. So this is cough, sputum production, hemoptysis, this is coughing up blood, dyspnea, shortness of breath, wheezing, cyanosis, bluish discoloration of the skin, chest pain, or sleep apnea. So, what is coughing? How we can characterize coughing? Coughing may be voluntary or involuntary, productive or non-productive. Now, what means voluntary, involuntary? If I want, I can start coughing. Involuntary, I can't prevent coughing. I can't stop coughing. That's why we talk about voluntary or involuntary coughing. By the way, what is coughing? Coughing, this is protective reflex. Coughing, this is protective reflex. What for we need coughing? We need coughing to remove some pathological stuff from our lungs. This pathological stuff may be produced in lungs like sputum, or maybe occasionally inhaled foreign bodies, for example, in lungs, especially it's happened in children. So that's why we need coughing as protective reflex to remove bad stuff, pathological stuff from our lungs. Then productive or non-productive. Productive sometimes we refer as moist, non-productive dry. Now this is very simple. If coughing leads to evacuation of sputum. In this case, we talk about productive. So coughing with sputum, this is productive coughing. Coughing without sputum, this is non-productive coughing, or dry. Now we have different descriptions of coughing. There are different types of coughing. Now, for example, dry, hacking coughing, typical for viral infections. And again, remember about this COVID-19, one of the main signs, this is dry, hacking, non-productive coughing. The dry, non-productive coughing due to interstitial pneumonia. Coughing may be chronic productive. So this is usually a result of chronic disorders like chronic bronchitis, bronchiectasis, bacterial pneumonia, or even tuberculosis. Coughing with wheezing. Now, usually this is asthma. This is bronchospasms and asthma. Now, there are some other types of coughing. Now, for example, morning coughing. Coughing which happens in morning. This is usually happens in patients who are smoking. But we'll talk later that this is not sign of smoking. This is sign of COPD, chronic obstructive pulmonary disease, which happens if in case of smoking. Smoking leads to development of COPD, chronic obstructive pulmonary disease, and one of signs of COPD, this is smoking. This is smoking. Sputum production. Next symptom or sign. This is sputum production. Sputum is the substance expelled by coughing. So substance expelled by coughing, we call sputum. Sputum may contain cellular debris, mucus, blood, pus, microorganisms. So what appear in lungs in bronchial tree and coughing up, we refer sputum. Now, sputum should be described according to color, consistency, quantity, number of times it's brought up during the day and night, and the presence or absence of blood. So if your patient complains of sputum, you should ask him about what is the color of sputum, what is consistency, liquid or non-liquid, quantity, amount, how much, because for example, in case of lung abscess, patient may cough up to 1 liter of sputum. Number of times it's brought up during the day and night, no presence or absence of blood. What about blood? So we use term hemoptysis. Hemoptysis is the coughing up of blood. The coughing up of blood, sputum with blood, known as hemoptysis. So coughing up clots of blood, pure blood, clots of blood, is a symptom of extreme importance because it often heralds a serious illness. On the other way, blood-tinged sputum is usually associated with smoking, minor infections, but it can be seen with tumors and more serious diseases as well. So it means that hemoptysis is a very important sign, but not in all cases it's some kind of tragedy or catastrophe. You know, if you suffer just from simple bronchitis and you're coughing a lot, it may cause damage of small vessels and you're coughing up some blood-tinged sputum. It's not benign. But on the other hand, again, it may be a result of serious destructive processes in lungs, like cancer, TB, abscess. Next sign, you know already, you know about this sign discussing heart problems, and this sign is known as dyspnea. This is subjective sensation of shortness of breath, the inadequate breathing or shortness of breath. So we call it dyspnea. Dyspnea. You know that we have different types of dyspnea. Now, first of all, if your patient complains of dyspnea, ask him what is more difficult for him, to inhale or to exhale. That's why we have two types of dyspnea. When patient experience problems with inhalation, inhale, and when patient experience problem with when patient try to exhale. So why it's important to know? So we refer inspiratory dyspnea and expiratory dyspnea. Inspiratory, patient can't breathe in, and expiratory, patient can't breathe out. It's very important because when we discussed heart problems, the most cases of heart dyspnea, this is inspiratory dyspnea. This is dyspnea when patient can't inhale, and this is sensation that not enough air. Now, if you run fast for a long time, you start experiencing dyspnea. This is so-called functional dyspnea. It's normal. And sensation you feel, this is inspiratory dyspnea. In some disorders, for example, in case of bronchial asthma, patient experiences expiratory dyspnea when he can't breathe out. He has problems with breathing out. Remember, please, that inspiratory dyspnea may be both a result of actually heart disorders and lung disorders. Now, for example, in case of again COVID-19 infection, patient experience mostly inspiratory dyspnea. He feel that not enough air. But if patient tell you about expiratory dyspnea, that of course he has problems with breathing in, but he experienced more problems to breathe out. This is usually a sign of lung disease. This is usually a sign of bronchospasms, bronchial obstruction, and this is typical sign of bronchial asthma. So expiratory dyspnea, this is sign of bronchial asthma in most of cases. You may ask how it's possible. By the way, why? We may experience expiratory dyspnea. Why expiration may be more difficult than inspiration, and why it happens in case of asthma. Explanation is following. How we breathe. Breathing in, this is a process when we use muscles. Now we have special muscles, diaphragm, intercostal muscles, and we tell that this is active process to breathe in. Now we have some force to breathe in. Expiration, usually this is result of elastic recoil of lungs and our chest. So breathing out, this is passive process. And that's why when we have bronchial obstruction, when in case of bronchial asthma we have spasm of bronchi, it's difficult to pass through these obstructive bronchines both in inspiration and expiration. But as inspiration, this is active process, we have force to breathe in. But expiration is passive process. We don't have muscles to squeeze lungs. And that's why if we have bronchospasm, if we have narrowing of lumen of bronchi, breathe out is more difficult to breathe in. Okay, other types of dyspnea. No, paroxysmal nocturnal dyspnea, sudden onset of shortness of breath occurring at night during sleeping. Orthopnea, difficulty breathing while lying flat. You know already. For example, paroxysmal nocturnal dyspnea, this is usually a sign of so-called cardiac asthma or pulmonary edema. This is usually happened in cardiac patients. Orthopnea, difficulty breathing while lying flat. You know, yes, orthopnea usually happens in case of left ventricular failure in heart problems patients, but at the same time, patients with bronchial asthma attack also prefer to stay in sitting position. And when he tried to lie flat, he experienced difficulties in breathing. That's why orthopnea may be both in heart problems and lung problems. Next sign, wheezing. Wheezing is an abnormally high-pitched noise resulting from a partially obstructed airways. So this is some whistling sound, I may say, some wheezing sound. Sometimes it's even distant sound. You just stay near this patient and hear this noise. You even need no phonenoscope to find this wheezing. No, usually asthma is associated with wheezing, but not all wheezing is asthma. No, remember again, wheezing is one of signs of asthma, but not all cases of wheezing. This is absolutely asthma. Next sign, cyanosis. Next sign, cyanosis. Cyanosis is bluish discoloration of skin. We have two types of cyanosis, central cyanosis, peripheral cyanosis. So why bluish discoloration of skin happens? This is, it depends on inadequate oxygenation of blood, because you know that arterial blood rich with oxygen has a scarlet color, bright scarlet color. Venous blood, this is dark blood. And that's why when actually we have lack of oxygen in our blood, color of blood changed, and actually we have specific color of the skin. So we have two types of cyanosis. Central cyanosis occurs with inadequate gas exchange in the lungs that results in a significant reduction in arterial oxygenation. So what means central cyanosis? Central means that all skin becomes bluish discolorated. Yeah? In case of peripheral cyanosis, this is inadequate or excessive extraction of oxygen at periphery, limited to cyanosis of extremities, fingers, toes, nose, and peripheral cyanosis also we call acral cyanosis. Acral cyanosis. Acros means fingers in Greek. That's why acral cyanosis means this is cyanosis of fingers, no toes, nose, peripheral parts of patient's body. Peripheral parts of patient's body. What you should remember, peripheral cyanosis, this is usually a result of heart problems. Central cyanosis, maybe both heart and lung problems, but actually in case of lung disorders, we meet central cyanosis. But nevertheless, even in case of central cyanosis, most visible cyanosis happens again peripherally. Lips, fingers, nails, patient nails becomes bluish, and again, presence of such kind of cyanosis, all kinds of cyanosis. It tells us about severe condition of patient, for example, with COVID-19 infection. One of serious signs of COVID-19 infection, this is bluish discoloration of the skin. And it's best finds bluish discoloration of nails, of lips, of nose. This is small device known as pulse oximeter. This is small device measure saturation of oxygen, of blood with oxygen. And actually clinical signs of low saturation, this is cyanosis, bluish discoloration of skin. Next sign, chest pain. Chest pain related to pulmonary disease generally results from involvement of the chest wall or parietal pleura. And pleuritic pain, common symptom of inflammation of the parietal pleura. So what we're talking about? Lungs, as other parenchymatous organs, like liver, kidneys, all these organs, they have no pain receptors. And that's why, just imagine, patient may have destructive process in his lungs, huge cavity due to lung abscess or TB, but experience no pain at all. Destruction of lung tissues bring no pain. How it's possible? Just no pain receptors. No pain receptors, no feeling of pain. And that's why when patients with lung disorders may experience pain, we have a lot of pain receptors in pleura. We have a lot of pain, pleura cover lungs. Pleura cover lungs, and if we have involvement of pleura, we talk about pleuritic pain, and this is inflammation of parietal pleura. Inflammation of parietal pleura. Remember anatomy, we have visceral pleura, parietal pleura. We have pleural cavity. And remember, if patient with lung disorders experience pain, it means that this is involvement of pleura. Two patients with actually pneumonia. If focus of pneumonia placed somewhere deep in lungs, patient has no pain. But if the same inflammatory focus placed nearby pleura and we have involvement of pleura, in this case, patient experience pain. So it depends, or it depends on involvement of pleura. Next sign, sleep apnea. Sleep apnea. Now, sleep apnea syndrome is potentially disabling condition characterized by excessive daytime fatigue or sleepiness, disruptive snoring, episodes of upper airway obstruction during sleep, and nocturnal hypoxemia. Actually, sleep apnea is not exactly lung disease. Sleep apnea usually happens why? Remember anatomy. In our oral cavity, we have palatum durum and palatum mollis. Palatum mollis, this is soft tissues, which actually controlled only by muscles. And these soft tissues, they make closed airways. And it's happened at night because all muscles relaxed diet at night, this palatum mollis can close airways, and as a result, patient experience sleep apnea, the episodes of absence of breathing. Now, clinically, it's also presented as snoring. If patients experience these episodes of sleep apnea many times at the night, again, it's lead to low oxygenation of blood, and patients wake up fatigue, sleepiness, because it's not normal sleep. Okay, next topic, physical examination. Physical examination. What we can do with patient? We can do inspection, palpation, percussion, auscultation. We have a lot of methods to examine lungs. We have a lot of methods to examine patients' lungs. Inspection, palpation, percussion, auscultation. So what we can find, for example, in inspection, just observing patient. Well, for example, we can find different configurations of the chest, different types of the chest. For example, we may see normal chest, we may see barrel chest. Why it's called barrel? Because actually chest look like a barrel. You see it's expanded in different ways, and actually this is usually a result of emphysema, result of COPD, chronic obstructive pulmonary disease, result of severe asthma, for example. We may have different kinds of curvation of spinal cord, for example, kyphosis, scoliosis, kyphoscoliosis. As ribs attached to the spinal column, it's cause actually changes in the shape of the chest too. Pectus excavatum, we have some excavation of the chest. That pectus corneatum, or pigeon chest. Pigeon chest, classically this is result of rachitis, deficiency of vitamin D in childhood. In this case, we have pigeon chest or pectus corneatum. This is other pictures. For example, pectus excavatum or pectus carinatum, so pigeon chest, pigeon chest. Okay, what else we can assess? Next, what we assess, this is actually respiratory rate and pattern. Respiratory rate and pattern. So, what we can say about respiration? By the way, one tip, actually. You know that respiration is something we can control. If you wish, we can stop breathing. If you wish, we can start breathing faster or deeper. And that's why when you examine your patient, try to do it insidiously. What I mean, never tell patients, now I'm starting examine your respiration. Because for some reason, involuntary, patient may start breathing faster, for example, to show you something. And that's why what you can do, you can give your patient that you examine, for example, patient pulse, and at the same time, you just see how patient breathes, how his chest expands. And based on this investigation, based on this observation, you can find what? You can find, first of all, respiratory rate. So, due to the rate, it may be bradypnea, tachypnea. This is the same as for heart. Tachycardia, bradypnea, rare breathing, tachypnea, fast breathing. Normally, at rest, patient's breathing rate should be about 16, 18 breathing movements per minute. Less, we talk about bradypnea, more high, we talk about tachypnea. Apnea. This is absence of breathing. For sure, of course, patient can't live without breathing. If you see that no breathing, wherever, this is apnea. Hyperpnea, we use term, or Kussmaul's breathing. This is specific type of breathing. Typically find, for example, in case of diabetes mellitus coma, in case of diabetes mellitus, ketoacidotic coma, this acidosis which happened in such patients force respiratory center to breathe faster and deeper to remove carbon dioxide, and as a result, patient breathe deep and fast. Deep, fast breathing, known as Kussmaul's breathing. Hyperpnea. Again, different types of abnormal breathing. Apnea, absence of breathing. Kussmaul, this is deep and fast breathing. For example, we have Cheyne-Stokes breathing. When patients start breathing shallow breathing, then normal breathing, then shallow breathing, then absence of breathing. In this case, we talk about Cheyne-Stokes breathing or Biot's breathing, breathing, absence of breathing, breathing apnea. So all these pathological patterns tell us about extremely severe condition of patients. This is actually maybe already dying of patients, because breathing, this is, we can't live without breathing. And if this breathing affected, it means that something terrible happened. Next, what we can do, palpation. Palpation of the chest. Of course, we can't palpate lungs. Lungs covered with ribs, muscles, skin, actually. That's why we can do palpation of the chest. What we can find? Areas of tenderness, symmetry of the chest excursion, tactile fremitus, the tactile fremitus. And in many cases, tenderness we can find on palpation. This is not tenderness due to lung problems. Actually, vice versa. If on palpation you find some tenderness, patient feel pain on palpation. This is usually not lungs. This is superficial structures, muscles, ribs, nerves. Real problems with lungs, you can never relieve some tenderness or pain on palpation. No, there are some exceptions. For example, gangrena, sometimes they refer that it's cause pain in intercostal spaces. But again, typically, if patient complain of chest pain, you touch this place and patient tell you that it's painful, in many cases, in most of cases, it's not lungs. It's not lungs. This is something superficial. No, actually, symmetry of chest excursion. It's clear because we have a left and right lung, and normally it should be inhale and exhale symmetrically. If we have some delay in excursion of one side, no, it may tell us about some pathology on this side. Tactile fremitus. When one palpates the chest wall while individual is speaking, these vibrations can be felt and termed tactile fremitus. Because what does mean speech? Speaking, this is vibration of our vocal cords, which cause vibration of air. But the same vibration conducted in different ways, including our chest. And these vibrations may be felt on palpation. And this is known as tactile fremitus. Now just do experiment. Put your palms on your chest or neighbor chest and ask him or yourself to say something like 99. And you feel these vibrations. You feel these vibrations. And tactile fremitus provides useful information about the density of underlying lung tissue and chest cavity. So what we're talking about? You know that lungs, this is air-filled tissue. And air was conductor of acoustic waves. No, we use speech to talk, and we believe that air is very good to conduct vibrations. But really, this is physical law. More dense stuff or tissues, better conductor for acoustic waves. For example, water can conduct acoustic waves better than air. And that's why, I don't know, dolphins, they can speak actually a few kilometers with other dolphins. We can't speak using our speech to ask some other person who is a few kilometers out from us, far from us. So, and that's why these vibrations, tactile fremitus, increased when we have high density in lungs. What is high density in lungs? This is usually pneumonia. Pneumonia causes filling of alveoli with exudate, with special plasma, the exudate, and the result, it becomes dense. Dense tissue, better conductor for acoustic waves. That's why on affected side of the chest, tactile fremitus increase. Vice versa, for example, if you have, I don't know, pneumothorax, when actually pleural cavity filled with air, tactile fremitus disappear, because air, this is not good conductor for acoustic waves. Next method we can do, this is percussion. Now, percussion refers to tapping on a surface to determine the underlying structures. Percussion over a solid organ, such as a liver, produces as dull, low amplitude, short duration note without resonance. No, this is actually from your daily life, you know such ideas. For example, if you beat drum, drum, yeah, it creates very loud sound. Why? Because it's contain air, actually it can produce resonance. But if you beat, I don't know, actually, some soft stuff, for example, pillow, you can hear nothing. Because again, solid organ such as liver produce dull, low amplitude, short duration note without resonance. Percussion over structures containing air within a tissue, such as lungs, for example, produce a resonant, high amplitude, low pitch note. So more air in tissues, actually more intensity of this sound, Percussion over a hollow air contained structure such as stomach produces a tympanic, high pitch, hollow quality note. If you, it's like a drum. If you do percussion of some organs which contain, which structures containing air, for example, stomach. The stomach has air bubble inside. It produces tympanic high-pitched sound. Percussion over a large muscle mass, such as head, produce flat, high-pitched note. So it depends. It depends. So, and based on this, what we can detect? What we can detect in percussion? We can why it's important for examination of lungs? Because lungs air-filled organ, and that's why changes in this structure of lungs can cause changes on percussion sound. Again, normal percussion sound of lungs is clear. Now imagine that patients suffer from pneumonia, alveoli filled with liquid, with exudate. As a result, percussion of this side of lungs, of this part of lungs, leads to appearance of dull sound. Instead of lung sound, we can find dull sound. So based on this, we can say that patient has pneumonia, for example. Next method of examination, auscultation. So when we do auscultation, we use phonendoscopes. Actually, again, what does it mean? Sounds. Sounds, this is vibration of something. If you hear something, it means that something vibrating. If you apply phonendoscope to lungs, you should hear something. You should hear some lung sounds. And we have different types of lung sounds we can find. You see, it may be tracheal breathing, bronchial breathing, bronchovesicular breathing, vesicular breathing. But remember, there are two main breathing sounds. This is vesicular sound and bronchial sound. Vesicular sound and bronchial sound. What is it? Let's start from vesicular, because it's normal. Vesicular breath sounds, this is normal sound. And if you apply your phonendoscope to your chest, to the projection of lung mass, you can hear this vesicular breathing. This vesicular breathing sounds soft, low-pitched sounds heard over the most lung fields. Inspiratory component longer than expiratory component, which is also much softer and frequently inaudible. So what actually vibrating in case of vesicular breathing? This is huge amount of these bubbles, alveoli. When air enters this alveoli, air beats alveolar walls, they vibrating and creating billions of these alveoli create this vesicular breathing sound. It's called vesicular sound because it's vibrations of vesicles. How do we know that this is actually a vesicular sound? Of course, it's better one time to listen than 1 hour to talk. But nevertheless, this is typically very soft, blowing sound, I may say. And what's important, that inspiration longer than inspiration and louder than expiration. Inspiration longer and louder than expiration. Explanation is following. When we again inhale, we use our muscles, air with high intensity enter alveoli, create vibrations. When we exhale, this is passive process, slowly air go out and producing less vibrations. That's why soft sound with long inspiration and short expiration, this is vesicular sound. This is vesicular sound. And normally, healthy lungs produce vesicular sound. Now, what about bronchial sound? Bronchial sound. You know, if you put your phalangoscope under trachea, you can hear different sound, different types of sound. This sound is usually more harsh, more harsh. It's look like as air pass through tube, and usually time of inhale shorter than time of inhale sound shorter than exhale sound. This is vice versa. In vesicular breathing sound, we have long inspiration, short expiration. In bronchial sound, we have short inspiration and long expiration. And quality of sound is different. Vesicular sound is soft. Bronchial breathing is harsh, we may say, louder, harsh sound. So again, breathing sounds loud, high-pitched sound, and like air rushing through a tube. Expiratory component is louder and longer than inspiratory component. And these sounds normally heard when one listens over the manubrium or under trachea. So, what does it mean? What for we need this breathing with this actually bronchial sound? Again, normally, if you put your phalangoscope under trachea or under big bronchi, you'll find this bronchial sound. Where the sound produced, what vibrating? This is not vibration of trachea or bronchi. You know, this is vibration of vocal cords. Even you speak nothing, even you keep silence. When air passes through vocal cords, and what vocal cords? Vocal cords, this is two actually vocal cords, and when air passes through, this is some narrowing. And air create vibrations of these vocal cords. And these vibrations we can hear as bronchial or tracheal breathing sound. And normally it's heard only under trachea or under manubrium of sternum, where we have big bronchi. Now, if it's normal, what for we searching for this? You know, we are searching, by the way, why expiration longer than inspiration? This is due to anatomy of vocal cords. They placed in larynx under some angle. And when we inhale, this actually vocal cords opening and air easily go into lungs. But when patient exhale, this airflow a little bit close actually vocal cords. As a result, we have small opening and air pass through this small fissura, through this small opening, create vibrations, and that's why expiration sounds longer than inspiration, longer and louder than inspiration. This is difference between vesicular breathing and bronchial breathing. Okay, if we can find vesicular breathing normally under lungs, if you can find vesicular bronchial breathing normally under trachea, under trachea it's also known as tracheal breathing. What this can give us in terms of diagnosing, it can give us a lot, because we are searching for pathological bronchial breathing. What does it mean, pathological bronchial breathing? Pathological bronchial breathing is when under lung fields, where normally we should find only vesicular breathing, suddenly you find bronchial breathing. So remember, if somewhere out of trachea or the manubrium of sternum, you find bronchial breathing under lungs, this is pathology. This is pathological bronchial breathing. Question: how this vibration from vocal cords can reach faraway parts of lungs? And what happens with vesicular breathing? What does it mean if we find bronchial breathing instead of vesicular breathing? It means following. So it means so-called consolidation of lung tissue. Consolidation of lung tissue. Lung tissue becomes solid. What can make actually lung tissue solid? Not the same pneumonia, for example. Because in case of pneumonia, we have filling of alveoli, with exudate, with specific exudate, plasma, result is following. If alveoli filled with liquid, they can't produce vesicular breathing, because vesicular breathing, this is vibrations of alveoli when air enters alveoli. But alveoli filled with liquid, with water. And the result, no vesicular breathing. Vesicular breathing disappear. No way can say, okay, in this case, we should hear nothing, silent chest. But it's not true, because actually these vibrations, which created by vocal cords and known as bronchial breathing, through our bronchi, which are tubes, can reach this affected part of lungs. And through dense tissue, because dense tissue, good conductor for acoustic waves, can reach surface of the chest, and as a result we can hear actually this bronchial breathing instead of vesicular breathing. And it tells us about consolidation of lung tissue syndrome. This is usually pneumonia, for example. This is usually pneumonia. Bronchovesicular breathing happens when we can hear together bronchial breathing and vesicular breathing. No, it may happen, for example, when we have pneumonia, focus of pneumonia surrounded with healthy tissues. In this case, healthy tissue give us vesicular breathing, dense tissue give us bronchial breathing. We talk about bronchovesicular breathing. No, vesicular breath sounds soft, low-pitch sounds. No, again, I told you about vesicular breathing already. So, no, some breaths. Vesicular breathing, long inspiration, short expiration, and short and soft quality of this sound. Bronchial breathing, short inspiration, long expiration, and harsh sound, the harsh sound. Bronchovesicular sound as inspiration look like vesicular breathing, and expiration look like bronchial breathing. And the result, we have the same duration of inspiration and expiration. Again, few words about bronchial breathing using picture. Just imagine that right here, we have inflammation. We have consolidation of lung tissue. And actually, as a result, no vesicular breathing. If you put phanendoscope under this area, you can't find vesicular breathing, because here we have solid tissue and filled with exudate alveoli can't produce vesicular breathing. But sound which created in larynx through these tubes can reach this place through dense tissues reach surface of lungs, and if we put phanendoscope here, we can find bronchial breathing. Okay, we talk about main breathing sounds, vesicular or bronchial. But also examining lungs, we can find adventitious sounds, adventitious sounds. Adventitious sounds known as crackles, wheezes, raunchy, pleural rubs. Sometimes we use, in Russian literature, we use term rails, хрипы по-русски, in English, rails. And we divide these rails into moist rails and dry rails. Moist rails, dry rails. Okay, what is it? The moist rails, also known as crackles. No, dry rails in English, in American literature, known as raunchy. The crackles, this is moist rails. Raunchy, this is dry rails. So, okay, let's talk about mechanism. When we can find moist rails and dry rails, or moist rails crackles. In case of inflammation, in case of bronchitis, in case of pneumonia, actually, we have production of mucus. We have production of sputum. Yeah? And this sputum fill actually alveoli, fill bronchi, fill these tubes. And what happens? If air passes through tubes which filled with water, it creates specific bubbling sound. Specific bubbling sound. Not just imagine, you take cocktail tube, put it into your cocktail and blow. What happens? You can hear bubbling sound. Bubbling sound. And the same happens in lungs. So usually most rails, this is results of presence of appearance of mucus, of sputum in bronchi. In bronchi. Based on the size of bubbles, I may say, we can say about fine crackles, we can say if small bubbling, small bubbles, fine crackles, we can say that. or coarse crackles when this is big bubbles. Now, this is, of course, everything very subjective. But nevertheless, remember, moist trails, this is result of presence of some liquid sputum in patient bronchial tree. Together with crackles, together with moist trails, very similar sounds known as crepitation. What is the difference? Crepitation also look like some bubbling sound, but crepitation appear in alveoli. And crepitation tell us about damage of alveoli, about inflammation of alveoli, and may appear, for example, in initial stage of pneumonia. How we can differentiate moist trails and crepitation? What is crepitation? Now just imagine, alveoli, this is bubbles or sacs. When we inhale, they expand, exhale, they actually reduce in size. And if inside alveoli we have exudate, exudate still can't completely fill alveoli, but it's already present. What may happen? When patient exhale, this exudate works as a glue and alveoli shut down. When patient inhale, air open alveoli, and this opening happen to appearance of specific sound known as crepitation. And that's why this is different. Moist trails may be heard both on inspiration and expiration because air first enter lungs, then leave lungs, passing through the area with exudate in these tubes. And that's why, again, moist trails heard both on inspiration and expiration. Crepitation heard only on the top of inspiration when we have opening of alveoli. That's why crepitation heard only on the top of inspiration. What else? After coughing, moist trails may change because after coughing, mucus can go out and, for example, moist trails disappear. Crepitation never disappear after coughing because this is process in alveoli and you can't remove sputum, you can't remove exudate from alveoli by coughing. Dry rails or rhonchi. This is result of also presence of sputum in bronchi, but this is usually very solid sputum, I may say, solid sputum. And this solid sputum can create different narrowings in bronchi. And when air passes through narrowing of bronchi, the same may be caused by bronchospasm. Bronchospasm also causes narrowing of bronchi. And when air passes through narrow places of bronchi, they create dry rails. This is different kinds of noise, the high-pitch noise, low-pitch noise, some we refer, the high-pitch dry rails, low-pitch dry rails. Now this is result again of narrowing of bronchi caused by presence of solid sputum or viscous sputum, I may say, viscous sputum, or bronchospasm, for example, in case of bronchial asthma. Wheezes continuous musical high-pitched sounds heard mostly during expiration, produced by airflow through narrowed bronchi. And this narrowing may be due to swelling, secretion, spasm, tumor, foreign body, commonly associated with bronchospasm of asthma. Actually, other words, wheezes, this is high-pitched dry rails, we can say. Actually, in Russian medical literature, you even can't find translation for the term wheezes. We just tell that this is just dry rails, high-pitched dry rails, high-pitched dry rails. Now, rhonchi, low-pitched sounds, which referred as dry rails in literature, in English literature, they also known as rhonchi. They believed to be more common with transient mucus plugin for movement of airways secretion. And finally, pleural friction rubs. Pleural friction rubs. You know that we have visceral and parietal pleura. Usually this is two smooth layers, two smooth films lubricated with pleural fluid, and they just smoothly slide when we inhale and exhale. What is pleural friction rub? It's happened when we have inflammation of pleura, pleuritis. In case of pleuritis, surface of this pleura becomes rough due to deposition of fibrin, damage of pleura. As a result, we have two rough surfaces. And now imagine what happens if we slide two rough surfaces. It creates some sounds, And this sound is known as pleural friction rub. It's resembling dry rails or raunchy. How to differentiate? Is it pleuritis or this is some rails? Is it happened in pleural due to pleural damage or due to bronchial damage? You know, there are different actually methods described in textbooks, but please remember one very simple test. Ask your patient to close his nose and mouth and do breathing movements. Close nose, mouth, and try to breathe. Try to do breathing movements. Result is following. If this is rails happens in bronchi with closed nose and mouth, air can't enter lungs. As a result, nothing, no sounds. But if it's pleural friction rub, even nose and mouth closed, we move our chest, it causes sliding of visceral and parietal pleura and cause appearance of pleural friction rubs. So we can say this is rails, raunchy, or this is actually pleural friction rub. Okay, that's all for today. If you have any questions, please type. I'll try to answer.